There's nothing boring about menopause care. It is the most challenging of any type of medicine ever I've done because every woman is different. There's a little bit of art to the science. And I always say to women, don't ask your friend because she's on a 0.375 milligram patch, and should you be, because your body's going to be different than hers, and you need to be patient. So I will get portal messages like, I've been on this for 3 weeks, I haven't lost weight. And I'm like, and so I try to reinforce, like, it's not a silver bullet. It's not going to fix everything. And especially women who are like in super stressful situations and they're not sleeping and they're not exercising at all. And they're really, I'm like, we have to kind of really boost your pillars up.
Welcome to Fated to Fabulous, the podcast for women who know that midlife is not the end. It's the beginning of something bold. I'm Kim Lovely, and I'm here with Vicki Kirby. We're here to talk to you about health, hormones, confidence, and joy. Midlife isn't about fading away. It's about stepping into your power and shining brighter than ever. Let's get into it. Hi, ladies. Welcome to Fated to Fabulous. We are so happy that you are back with us again. So our topic today is to circle back to the conversation about hormones. We have talked about it quite a bit, especially we did some lengthy podcasts in the past, but there's new things and new ways of doing practice, and Vicki's experiencing new things in her practice. Mm-hmm. So we're going to circle back and talk about what's happening out there, Vicki. What's going on?
This was a topic because, we're always trying to think of like new and innovative things to talk about, and we want to make sure that we're reaching everyone. So I did have somebody who loves our podcast and watches it, and I said, what would you want us to cover a little bit more? And she said, you talked about hormones in kind of the first couple of episodes, but I'd love to have more information because I think women get really inundated and there's almost too much information, and then they feel conflicted. So, and I've learned, this has been a journey. Yeah. And so I have learned a lot in the last couple of years doing this type of practice. So I wanted to kind of like just touch base about some of the big things that we've seen.
So before we get on to our main topic, we usually have something to say that might be funny or silly or yucks and yums. So today we're going to talk specifically
We both had some yums.
Yeah, we had total yums.
We both had vacations where it was just women.
Yep.
And it's not that I don't love my husband. And like, of course, I enjoy my family and whatnot. But there's something about just being with women that, especially when they're really good women, you feel that you are present and in the moment and there's no pressure and you all just sort of jump in and do the things. Mm-hmm. So one person gets the snack and somebody else cleans it up. And so it's
Do you know what word I would use?
What?
Easy.
Yeah. This is why women are getting tiny houses and all living together.
Yes.
Wink, wink.
It's funny because I had a trip with my friend Jennifer Little, and we just kept saying as we were going along, like, you're so easy to travel with. Yeah. Like, it was just easy. We had our funny moments, things came up where we had to sort of pivot and make a plan B, and each time it happened was better than the original plan A. And I just found that there's just opportunity for growth. There's opportunity for depth of conversation, which I think a vacation with women allows. Like, we can talk about some things that you can't really talk about, just over a cup of coffee, right? Mm-hmm. It needs a little more time. It's restorative. Mm-hmm. It feels really good. And I don't know what about you guys, but I know you explored some areas of clothes, and that makes me very happy. We explored some new things. We did some things that, we had a pickleball lesson. We went to a sound bath ceremony outside under the stars. We went to a functional class. Like, we did some things that were sort of outside of typical. And I think you can make it funny and silly.
Yeah.
And that's just...
Yeah. And you're with women that you feel comfortable with. It's just... an amazing experience. So we love
Yeah.
women, and that's why we wanted to
want to share
talk
that
about our
piece.
experiences.
So if
That's why
someone
we're
says,
both extra smiley
yeah,
today.
if someone says, "Hey, do you want to go?"
I was, my best friend is like, okay, we're doing this. And I have gotten, as I've gotten a little bit older, I'm sort of like, I like my house and my dog and my husband, do I really want to? And I'm so thankful that I went. It was
Yes.
absolutely amazing experience.
Yes.
So,
Yeah.
all right, let's dive in and talk a little bit more about hormones. What's kind of going on?
What are you seeing out there with regards to, maybe some new things, some things that you've learned? Go.
I want to just kind of give some, these are things that I share individually with clients when they come and see me, but they're things that I want you to know as well, in case you're seeing a clinician who's maybe not at that place of comfort with their hormone therapy. There's some things that can be kind of nuanced about it. So I want all women to have access to that information. So an example, when you're on hormone therapy, it can impact other things, and other medications can impact your hormones. So you want to be mindful of that and making sure that when you're meeting with somebody, you have somebody who has the full picture of your medical history, what you're taking. So example, if you are on thyroid medication, so Synthroid, levothyroxine, you may have to get, and you do go on hormone therapy, it may impact your thyroid results. So you may need to get blood work where you normally were going twice a year. After you start estrogen, you may need to go get some blood work done 6-8 weeks later. And I always just say to women, pay attention. Women know their bodies. So if you're noticing that you're feeling like you're hypothyroid, reach out and we can, order.
That would feel tired, like they're
Tired,
just all of a sudden
constipation,
tired, thinning hair, lustrous. What do you call that?
And also with the new other things that we're seeing are really incorporating GLP-1s. So I think I felt very differently about GLP-1s if you had asked me about it a couple of years ago. But taking care of women in midlife on repeat who come in and say, great, I'm on the hormone therapy. I think some women come in specifically thinking that hormone therapy is going to help them lose weight. It is not. Yeah. So can it? Yes. If you weren't sleeping and you had no energy and all of a sudden you're getting good sleep and you have the energy and the motivation to go do things, then maybe yes. But hormone therapy in and of itself is not a silver bullet for weight loss. So now we have these women who are like, okay, great. Now I'm on the hormones and I know I'm protecting my heart and all of these pieces. I'm not having hot flashes, but this 25 pounds is here and I'm doing all the right things. Those women do well.
They do.
With a lower dose GLP-1. But what you need to know, and you want to make sure that if you're seeing somebody who's giving you a GLP-1, that they're aware of some of the things that can be happening if you're on hormone therapy. So, for example, if you're on a GLP-1, it can lower the absorption or slow down the absorption of your progesterone. If you are taking progesterone in order to protect your uterus, now, all of a sudden, you may need a higher dose. So if you are going on a GLP-1, if you're increasing your dose, you may need to go up on your progesterone. From, let's say you're on 100, you might need to do 200. If you're that woman who's progesterone, like I can't do 200, Vicki. When I do 200, all of a sudden I'm so tired and and it doesn't go away over a few days. You can actually do the one you're doing orally and insert a second one vaginally.
Which I think is so cool.
Yeah,
that's
is
nuanced.
Yeah. So the vaginal use does not have the same wonderful impact on GABA in the brain, but it protects the uterus if you have a uterus.
And that GABA influence is amazing.
I did not take my progesterone last night. I had a hysterectomy. I don't have a uterus. I don't need one. I take them. I did not take it last night, and I
didn't fall asleep till 11.
Yeah, it was not a good night's sleep. My Oura ring was thoroughly unimpressed with me.
Yep.
So that's
crazy,
kind of
right?
like what I'm seeing with, some of the things that you want to be aware of as a woman who's on hormone therapy or thinking about it. We want to be thinking about this in the context of your entire medical history. It really is important.
So the other thing that I want to bring up is I am sending to you and Caroline, women in their 60s who have missed menopause care and not just missed like hormone replacement, but missed the whole
conversation.
Lesson. Yeah, no conversation, and have experiencing consequences of lack of estrogen in the girl parts and maybe living with chronic UTIs and vaginal dryness, and we're never offered vaginal estrogen. So we're sending those to you. So what's happening in the world of women in their 60s?
They're pissed.
Yeah.
So they're watching the podcast, or they, read an article and they come in. And, first of all, I'm going to address what they're there for. So what is it that's drawing them to have this conversation with me? So what's the complaint? So I hate this because it's every single day. I have a woman always in their 60s or 50s. They haven't had sex in 5 years. Or they're having sex and it's like
Painful.
Shards of glass. Awful. Awful. Where is your vaginal estrogen?
Yeah.
So at a minimum, they're not leaving without a lot of education, some vaginal estrogen, probably a moisturizer. Maybe we have to even have conversations about pelvic floor PT and vaginal dilators. But those women, I'm also going to say to them, if I have somebody coming to me and they're 12 years out from their menopause and they are playing pickleball and tennis and
eating well
and doing all of these things, like those are, and they're still having hot flashes. They have osteopenia.
Yeah.
We're going to have a conversation about the risks and benefits, and an educated conversation. Because I say this all the time. Not every woman is a candidate. Not every woman wants it, but every single woman deserves to have a conversation.
Correct.
So that is something that I'm seeing in higher and higher numbers.
And that's why I send them to you. I will say to them, whether or not you're a candidate, I don't know, but you are worthy of having the conversation of what the rest of your life is going to look like, right? This is not just, well, I got through my hot flashes, I'm okay. This is what's the rest of your life going to look like. So
I always say, what do we want to see at 80?
Yeah.
Same vein as that is the perimenopause woman, which I think perimenopause is really nuanced care. That is not, it has been the gold standard. Well, one gold standard is just basically like, pat, you're just a busy mom. That's why you're, sad, anxious, hating everybody. But I think we're learning more and more clinicians are getting comfortable with this, but really looking and saying, it's not bad care to offer someone a birth control pill or an antidepressant, because two things can be true. Like the woman might actually need birth control because she's still, she's sexually active and doesn't have a method, or she's having some really dysfunctional bleeding. And so that might be an option that makes sense. But it's not all that's in the toolbox. These perimenopausal women, they're in their 30s and 40s. It's the low progesterone, so it's the anxiety, irritability, insomnia, and then the lack of get up and go, and I have no libido because their testosterone has dropped down too. And we've talked about this before. We're seeing so much more evidence that we should be thinking about treating these women. And you don't want to wait until they're, because we have early, mid, and late perimenopause. If you're waiting, estrogen's like this in the beginning phases, but if we're waiting until it's really dropping down, then we're seeing the metabolic shifts too.
Yes.
The cholesterol going up, the blood sugar going up, their waist size going up. So perimenopausal women, if you are just solely being offered an antidepressant for your symptoms, it's not, again, because some women actually need hormones and an antidepressant, and that's okay. But if that's the only option being given to you, it's time to just keep asking and talk to somebody who gets it.
I have a young woman who is in the perimenopause journey, and she was literally told, come back when you're a year out of your period, and here's an antidepressant. And she's a very scholarly, wonderful woman. She was just kind of like, thanks. I'm moving. She didn't say to them, I'm moving on, but she was like, thank you very much. And in her brain, she's like, no, I'm going to keep asking because it's not just that. So, okay. So the next thing we wanted to talk a little bit about was progesterone intolerance. What is it? What do we do?
Okay, so if we're in talks of hormone therapy, if you have a uterus, you require, and you're getting estrogen, you require progesterone to protect the uterus from the growth or proliferation that happens from estrogen in the uterus. There are different types. They're not all the same. So typically, someone who's doing menopause care today is going to use body identical micronized progesterone. And this is how I explain this to women. I also, side note, give it to women who do not have a uterus.
Like yourself.
Like myself, because it is amazing for sleep, anxiety, irritability. It's a decent number of women, most women, I'd say, I feel like kind of are like, this is amazing. I am sleeping like a baby and I feel calmer, and that's great. Progesterone intolerance is, and there can be sensitivity and intolerance. Sensitivity might be the person who says to me, I'm always so sensitive to medicines and hormones, and it might be too sedating for them initially. So those women, instead of giving the one that they pick up at CVS, I might do it compounded at a lower dose and gradually work them up. Intolerance is a scream and not a whisper. Like, what did you give me? That was horrific.
I was awake all night long.
Yes.
Yes. It did the opposite of what it's supposed to.
Yes. So, and it happens. And so I make sure I educate everybody, this is a potential. In that case, it doesn't mean you are not a candidate for hormone therapy. It may mean that we talk about a synthetic progestin. It may be that we talk about a progesterone-containing IUD, particularly if you are looking for birth control at the same time. It may be that, I said earlier, change the route of delivery. You can use the pills vaginally. It's not going to give you the great impact on your sleep and your mood and whatnot and anxiety, but it's going to protect your uterus and allow us to do the estrogen. So that's kind of my 2 cents about that. I think it's really important. I think that women need to be aware of it as they're starting their journey, particularly the women who are getting their care from a 10-minute telehealth appointment with a big company. Do because realistically, like my visits are an hour. I can't imagine, getting every piece of that. So important piece.
Just before we leave the progesterone, I had a great thought. So as we age, do our needs for the hormones change? So I'll give an example. Like I was on just one tablet, so it's 100 milligrams, right, of progesterone, and I was doing okay.
Yeah.
And then all of a sudden, I noticed over a course of a month, I was waking up every 5 minutes, up every half an hour. Like my sleep was really disrupted.
Sure.
And I walked into the office one day and I said to both of you, hey, this is what's happening. And you both said, take 2. And game changer. Yeah. Is that because I might have hit some
Sure, or even if you had had adjustment of your estrogen, or also you had also started some testosterone around that.
Okay, so that will make a difference too.
Yeah,
okay.
And then also just life stress, right? So it's so tough to tease out sometimes what's hormonal, what's
It is a game changer as far as sleep.
Sure.
It works so well for me that if I don't take it at the right time, I don't get enough sleep.
Yeah.
I need to take it like half an hour before I want to go to sleep.
Yes.
And then I'm literally like out.
And every woman figures that out. Every woman figures that out, and it's different for everybody. Some women are like, oh, I take it after dinner because if I take it right before bed, I won't get to sleep, but I also will wake up groggy. So it's just I have some patients who will take it in the morning.
Really?
Yeah. It doesn't impact them that way. I'm like,
okay.
Oh, I couldn't drive if I took progesterone in the morning.
No, me neither. Yeah. Me neither. Yeah. Does it help does sort of melatonin function differently with progesterone? We don't know that, right?
You mean, can you take it at the same time?
No, I'm just wondering if natural melatonin behaves differently if progesterone is behaving better. Like I wonder
it works more GABA. Right? Yeah.
Interesting.
Yeah.
Okay, so the next question I was going to ask you was delivery methods of hormones.
Yeah.
And how that
This is an issue right now significantly.
Yeah.
So there's supply chain and manufacturing issues with estradiol biweekly in particular patches, which has led to a lot more work for me over the last few weeks of messages from patients. I'm sorry. I actually sent out a group message to all my patients. We're going to hear your options. The option isn't that you have to stop hormone therapy because you can't get them. I have some women who are like, I drove to Somersworth from Nashua. I'm like, what? Options, we can switch to a once weekly patch. They're bigger, they can peel off a little bit, and they tend to wear off for some women towards the end of the week. So not my fave, but a reasonable, like short-term solution. Gel, spray, so we have lots of other options. Interestingly, I made a social media video today, and I said, if it was Viagra,
that's what
it
I
would
was
be a
just gonna
national
say.
emergency if
Exactly.
there was a shortage.
Yes.
But
Yeah.
no, it's because it's estrogen. So anyway, and there's oral. I want to never exclude oral. It's not my go-to because I think that it's, we're safer using the patch form. But there are some women who do really well with oral as well. So just want you to know, if you're in the throes of this chaos, I want to lodge a complaint. Yeah.
Okay. And then, so this is an interesting subject. So frustration with care among different clinicians, and if somebody is seeing two different kinds of clinicians and getting different kinds of opinion, I guess, is that sort of some of the stuff that you're seeing?
And that is hard. That's hard. And I am in a group of clinicians who are all trained in the same program. And we all voice this as a universal, this is hard sometimes because if you go with 7% of providers feel comfortable managing menopause. So we have a whole sea of providers who've been trained since 2002 that hormones are dangerous. You run into some difficulty because for me, I am here to guide your patient, spend an hour, go through their history, talk about the risks and benefits, talk about the options. I don't want to take over your patient. I'm not stealing them from you. I'm not going to be their primary care. I'm not a gynecologist. I'm not going to do their pelvic care. That, they still need all of that. And so for me, kind of where I get a little stuck or frustrated is if I spend that hour and we go through everything and they go back to, and I warn them ahead, you may hear that you're not an appropriate candidate, or hormones are dangerous, or even people who Menopause Society certified providers telling patients you aren't a candidate for estrogen because of your migraines or because you had a blood clot, or all of those things that we now know. Transdermal or on the skin estrogen is safe. But it's just tough because then I'm doing a lot of back and forth kind of combating. And I want us all to get along. I want everybody to, I want this to become standard of care where it's in OBGYN practices, it's in primary care practices. But in the meantime, at least let's work collaboratively. It's fine. As a primary care right now in what they're struggling with, there is no way that to do the learning that I did over, the course of a year, it's really tough to find room to learn all these nuances. Yeah. But we do have, there's a primary care group that we really like. It's all nurse practitioners. And we send, I send people to them for primary care. They send people to us, but they reached out because they wanted us to come and help them navigate it themselves.
Yes.
Wonderful.
Yes.
So then, if you have a complicated person, send us a complicated person. We will get things started, send them back to you. And you can reach out when you need help because there's no shortage of menopausal women who need care. So I just want everybody to let's at least not counteract.
Yeah, and the hard thing is again, when that happens, who's caught in the middle?
Yeah.
The client patient, right? So that's the part that's frustrating, right? They're feeling like they've reached out to get care. They're doing the best that they can.
Right.
And then they get sort of I hate using the word gaslit, but yes, they kind of get gaslit. And then they sort of feel like, well, if I don't do what my original doctor tells me to do, then I'm going to be a bad patient. And then, so I think, if you notice that sort of stuff, right? If you notice that there's some of that, I think it's okay to sort of call someone on it, and not call them on it, but kind of say, you know what, let's work together. Let's collaborate on these things. It's just,
and there's tons of clinicians who are great, and even primary. I'm starting to get more and more referrals from medical providers versus women desperately seeking on the internet. Because I think they're getting okay, these patients actually did okay, and they're learning more.
Yes,
it's not anybody's fault that we were kept from any learning around menopause for 20 years.
Yeah. So the last area that we wanted to talk about was just sort of the unrealistic expectations, right? So there is a lot of buzz online, right? And I think sometimes women sort of are frustrated with what's happening and what care they haven't gotten, that they sort of have perhaps expectations that are not realistic. So talk a little bit about what does that look like?
Yeah. So that happens a lot. And I think it's because we have social media. It's one part of it, where it's like hormones saved my life. And I do have women that will say that to me like 100%.
Yep.
But one of the things that I do try to really stress to patients is patience. There's nothing boring about menopause care. It is the most challenging of any type of medicine ever I've done because every woman is different. There's a little bit of art to the science. And I always say to women, don't ask your friend because she's on a 0.30, milligram patch, and should you be? Because your body's going to be different than hers, and you need to be patient. I try to reinforce it's not a silver bullet. It's not going to fix everything, and especially women who are in super stressful situations and they're not sleeping and they're not exercising at all, and they're really, I'm like, we have to kind of really boost your pillars up. So it's realistic expectations, I think, is the biggest part of that. Just sort of be patient, work with your provider. There's always room to try a different form or go up or down. This is why I tend to I don't throw everything at you and see what sticks. We're going to do one hormone and then another hormone for a reason so that we have much less of that back and forth and frustration.
And not knowing. I think that's something that we need to just encourage people anyways.
Yeah.
Once you sort of hit this midlife journey, we're looking at what does the future look like. I'm not just worrying about my today and my tomorrow. I'm worrying about what's my life look like in 10 years' time, right? Yeah. So I'm looking at it for protection and prevention of things. So that's a bigger picture than just...
It's a harder sell for women who are not really symptomatic of their menopause and they're wanting to do it for long-term health. If they have a side effect, they're going to be much more or if they can't get the biweekly patches or whatever the frustration is, the pain point is. But, most of the time it's kind of what I will do, and I do have this happen very regularly too, is I will see somebody and they're like, I'm not better. I'm like, and I'll go back to their first note and I'll say, do you remember you were having, and I read off and I go, are any of the, well, yeah, I haven't had any night sweats. Yeah, I think my energy is a little better. My joints aren't hurting anymore. You're right. So it's just,
haven't yelled at anybody in a week.
Yeah. It's not like blood pressure where you take an antihypertensive, you take a blood pressure medicine, and then you recheck your blood pressure and you can see, it's 120/70. It's a little different. So you just be patient and make sure you're working with somebody who really can guide you and help you. Yeah. You're worth it.
Yeah. So we hope that this sort of update on what's happening in the world of hormones has been helpful. Feel free to give us comments, questions. We love them. Would you like to hear more about something? That would be terrific. Yeah. We will definitely address that. And, just so you know, we are so happy that you are tuning in. It means the world to us. Yes. Continue to do so. Share us with your friends. And until next time.
Thank you.
See you soon. Thanks for spending time with Vicki and I today on Fated to Fabulous, where midlife is just the beginning of your boldest chapter yet. If you got something out of today's episode, we'd love it if you'd share it with a friend and leave a review. Hit subscribe so you never miss an episode. And if you're looking for more support, inspiration, or sisterhood, come join us at fatedtofabulous.biz, because you were never meant to do midlife alone. Until next time, stay fabulous.